بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. أعزائي أبنائي إخواني الطلبة، نلتقي في محاضرة جديدة من سلسلة محاضرات ophthalmology made easy. As I have promised you before that we finished the first lecture regarding uveitis. We gave introduction to the uveitis and we discussed some of the clinical signs and symptoms of uveitis and general guidelines for the management. Now we dive deeply and start speaking about infectious uveitis, and we will start with the viral uveitis as it is the most common cause of infectious anterior uveitis. In this lecture, we will discuss the different causes of the viral uveitis and the different clinical manifestations and how we differentiate between them. We will provide some clinical case scenarios and we will discuss together how to solve them. Also, we will discuss the association of these infections with immune deficiency syndrome, and we will also concentrate on the laboratory investigation. So let's dive deeply and see what's inside, and I hope that you will enjoy and get benefit from this lecture. After this lecture, you will be able to answer all these questions, which are important for any postgraduate student. So concentrate so that you will be able to answer all these questions. In this lecture, we will discuss the detailed epidemiology of viral uveitis and discuss the principle of latency and understand the pathogenesis of the anterior uveitis caused by these viruses. And we will study in details the four main viruses, the herpes simplex and zoster, cytomegalovirus and rubella virus as causes of viral uveitis. And then we will discuss the laboratory investigation and the confirmation of the diagnosis, and finally briefly about the management and some of the complications. Now, as far as the epidemiology, if you remember from the previous lecture, we say that between 40 to 60% of anterior uveitis is idiopathic, and the remaining most likely is due to infectious causes of uveitis or autoimmune diseases. So the remaining 40% is divided between infectious causes and autoimmune diseases. And among infectious causes, the most common causes of infectious uveitis is viral uveitis. And viral uveitis constitute 10 to 15% from the overall anterior uveitis. So overall anterior uveitis, 10 to 15%. So you can imagine nearly 90% of the causes of infectious uveitis is caused by viral uveitis. And in the top, this is the four players, the most common four players for anterior viral uveitis, herpes simplex, herpes virus. All these belong to the herpes group of viruses, and also rubella virus. Also, there is some other viruses like Epstein-Barr virus, but this is rare. This is the most common players. Another thing that nearly 30 to 40% of the cases of viral uveitis are missed and undiagnosed or confirmed as viral etiology, and they diagnose it as idiopathic uveitis. And this is maybe due to the atypical presentation of the cases or because of the lack of the facility for PCR tab and confirmation of the diagnosis based on virology. This is the percentage or the prevalence of the seropositivity along the world. You can see that there's a high percentage of seropositivity for all these viruses in the different continents, and especially in Asia, cytomegalovirus is very prevalent, and also in Africa. That's why we should be very careful before starting steroid therapy for any patients with anterior uveitis, unless you make sure that he is not viral etiology. And in our next discussion, you will know how to rule out viral etiology based on the clinical pattern. These are certain demographic data we used to say that generally the herpes simplex affect people before the age of 60 years, and varicella zoster commonly affect people beyond the age of 60 years. Cytomegalovirus has a broad range of affections between 30 to 60 years. Similarly, rubella or a little bit young populations with general, there is male predominance. There is male predominance that you most likely you find that the viral uveitis is commonly seen in male. And another universal finding is the unilaterality, and this is very important that almost 90% of the cases are unilateral. And this is one of the way that you approach the case when you find a unilateral uveitis, especially if it is granulomatous. You always think on a viral etiology. And also a history of recurrence usually is high, especially in herpes varicella zoster, and also in rubella presentation, especially when it presents as Fox heterochromic uveitis. Another thing regarding the complications, the herpes simplex usually associated with keratitis, varicella zoster usually also associated with skin manifestations, and the common complications of cytomegalovirus is secondary glaucoma, and rubella is secondary cataract. So this is just brief epidemiological notes. And another thing that some category of people, they have increased risk of these viral uveitis, especially those with HIV positive and with CD4 less than 50 cells. This is high risk of cytomegalovirus retinitis. And this was very high, especially in pre-heart era. Heart stands for highly active antiretrovirus treatment for HIV. But now this percentage is decreased because of the availability of these medications. Another thing, cytomegalovirus is common in, uveitis is common in people with a transplant, with renal transplant or liver transplant. So these people should be screened for cytomegalovirus, and prophylaxis should be given in the form of valganciclovir. Acyclovir is not effective against cytomegalovirus, so we have to use valganciclovir. And another age group, as I said, that old people are prone to the varicella zoster, and herpes simplex below the age of 60 years. But age group, there is no exceptions that all age groups can be affected. Another point, as far as the risk of complications, as you can see that the complications, most of them, they have cataract and glaucoma complication, but the risk of cataract is much more in chronic cytomegalovirus infection, those one which present as Fox heterochromic uveitis. Nearly 75% of the patient will present as cataract. And also the same group of people affected by cytomegalovirus which present as post-Nash-Klugeman syndrome, they will present as glaucoma. I mean, what I meant to say that cytomegalovirus has more than one presentation. It might present as Fox heterochromic uveitis, previously was known as Fox heterochromic uveitis, but now confirmed to be due to cytomegalovirus, and they present as cataract. And another variety which is previously diagnosed as Poshner-Klugeman syndrome, and they present as glaucoma. However, the risk of cataract and glaucoma is present in all of the types of viral uveitis. Now we come to one of the important common criteria for all these viruses is what's known as the latency, or the indissoluble bond. All of these viruses that they belong to the herpes group of viruses, they have the feature that they being latent. Once infect the cells inside the body, they become inactive and they don't multiply, and will become as in the inactive state, so that it is hidden and not recognized by the body immune system. And for particular reasons, for example, the reduction of the immunity or any trigger like stress or menstrual cycle or any insult, this virus will be activated and multiply and can cause the disease. Now, this is known as the indissoluble bond. That's a very strong relation. The virus will be dormant inside the cells and it cannot be eradicated. You cannot treat it with antivirus at that stage, because all antiviruses are based on the multiplication of the virus, so that they block certain pathway in the multiplication of the DNA of that virus. However, these viruses, when they are dormant, in a dormant state, they are not an active multiplication, so that even antivirus drugs cannot affect them. They affect them only once they start multiplying, so they are useful for prevention of the multiplication. So that's why they are useful in the prevention of recurrence, but we cannot eradicate the disease. So keep it in your mind, there is no eradication from any viral infections like herpes simplex or virus or cytomegalovirus. What we do only, we just treat the acute stage of the disease, or we prevent the recurrence only by adding prophylaxis, but we cannot eradicate the disease. This is very important to understand why when we treat the patients with viral uveitis, we have to treat both the acute symptoms as well as the proliferation of the virus. So we have to cover with the steroid and antiviral. And even after the acute stage is subsided, we have to continue for a long time to avoid the recurrence of this virus. So based on this principle of indissoluble bond, there will be a recurrence. All these viruses, they will characterized by recurrence, and they will have a dormant stage. So by history, you will take the history of the patient, he will give you history of recurrent attacks of the same problem. Now the difference in the latency, the structural latency. Now for herpes simplex and herpes virus, they are named as neurotropic latency. It means they have a predilection for trigeminal ganglia for both, and varicella zoster also for dorsal root ganglia. So they have a predilection for the nerve cells. That's why it's named as neurotropic. However, cytomegalovirus is called epithelial or endotheliotropic because it commonly like to be dormant in the corneal endothelial cells, in monocytes in the blood and macrophages, retinal cells, and in myeloid progenitor cells in the bone marrow. So this is very important because when there is the reactivation of the cytomegalovirus, it depends on the local tissue where it is activated. And we can find just activation inside the endothelium, and the remaining cells of the body will be quiet because of the local activation. So this is one of the difference between the herpes simplex and virus and cytomegalovirus, the site and the location, and the corneal involvement in cytomegalovirus due to the endothelial reactivation can lead to corneal decompensation. So this should be kept in mind. And as I said, that the trigger factor is different causes like immunosuppression, physical stress, psychological stress, or hormonal changes. All these can trigger the activation. Now I will discuss about an important mechanism of the tissue damage that happens due to viral invasion. It is named as dual mechanism, that we have two mechanisms by which the virus will destroy and damage the cells inside the eye in the cases of viral anterior uveitis. Either by direct invasion, that the virus by itself invade the cells. This is called direct viral cytopathy. And this invasion will lead to destruction of the tissue itself, as happens in iris necrosis and stromal thinning. As you can see, where most of the viral uveitis, you will find destruction of the iris, loss of iris pattern, iris atrophy, and scalloped appearance. And also you will find damage to the corneal endothelium as in cytomegalovirus, and you will find trabecular damage, and the patient will have secondary glaucoma. Another mechanism is due to the immune-mediated mechanism, in which the host immune response to the viral antigens will create a lot of anti-inflammatory mediators, cytokines, interleukins. All they will destroy the virus antigen, as well as they will destroy the host tissue itself. This happens also in trabeculitis, and what you see in keratoconus precipitate is a sequelae for this damage and this destruction, and you will find mild to moderate inflammatory reaction in the anterior chamber. There is no severe reaction in viral uveitis as compared to the HLA-B27. Rarely you will find hypopyon, and rarely also you will find posterior syncytial. Posterior syncytial commonly seen in herpes zoster, but in cytomegalovirus and herpes simplex it is rarely, unless it is recurrent and chronic. But the percentage of posterior syncytial is more common with herpes zoster. Now this is known as the tissue tropism. Now the cell-mediated immunity, this is due to the predilection of the virus to specific tissues, and this will induce the immune system to attack these tissues. And also this explains the recurrence, as I said before, that the herpes simplex and herpes virus, they have predilection for the trigeminal ganglia and dorsal root ganglia, and once activated they will propagate through the nerve root and attack the eye. However, cytomegalovirus usually have predilection for the bone marrow, monocytes, and endothelial cells of the cornea. That's why you should understand it is a must that you give along with steroids, you have to give antivirus treatment. And if you give just steroids without antivirus, you are worsening the situation because you are reducing the immune response of the body. However, you are not treating the viral replication, which will increase when you use your steroid treatment. Another point, never use just topical antiviral, especially in viral anterior uveitis. Now, if you have keratouveitis, this is okay. You can give topical as well as systemic. However, in uveitis per se, topical antiviral are not effective because they have poor penetration and they will not affect the uveal tissue. So, topical antiviral are not useful in viral uveitis. Now, the same thing, this is a repetition of the same thing that we have the neurotropism, the principle of neurotropism, that the virus will stay in the dorsal root ganglia or in the hematogenous spread for cytomegalovirus. Just keep this in your mind because this is the pathogenesis of latency principle is very important. It explains the reactivation. It explains why we need the prophylaxis. It explains why we have to give combination of both steroids and antivirus. Now we will start giving special notes about the first incriminated virus, which is herpes simplex virus in this anterior uveitis. And I would like not to go deeply to the clinical manifestation because we have discussed before in the previous lecture the common finding, but we will concentrate in certain important points for you as a postgraduate that help you in the differential diagnosis. Now, herpes simplex, now more than 90% are unilateral, and as I said before that most of the, if not all of the viral uveitis is unilateral, almost always unilateral, okay? Sometimes it is bilateral, but it is rare, especially in immunosuppressed people. If you find bilateral uveitis, think of immune suppression. However, most likely, almost always, the viral uveitis is unilateral. Another thing, common feature, is the presence of sectorial iris atrophy. Now, as I said, the sectorial iris atrophy is due to necrosis of the iris, due to vasculitis associated with this viral uveitis. And keep this term in your mind because in the herpes virus, herpes zoster virus, it will be segmental iris atrophy. What's the difference between sectorial and segmental? Now, in sectorial iris atrophy, you have multiple small batches of iris atrophy involving one sector or more than one sector. However, in herpes zoster, there will be involvement of a segment of the iris based on the innervation of that virus. Innervation of that iris. Yeah, so because the virus would follow the nerve roots, so you find segmental iris atrophy. This is very important. 50 to 60% associated with elevation of the intraocular pressure, and most likely is granulomatous. Now, we say in the previous lecture that herpes or viral anterior uveitis can be both granulomatous or non-granulomatous. Herpes simplex commonly is granulomatous uveitis, and the recurrence rate is between 30 to 50%. So 50% have a chance of recurrence. This is special features for herpes simplex. This is the picture of granulomatous uveitis. Another point that you will find, the KBs is distributed beyond the Arlet's triangle. You remember that in this lecture we said that in most of the uveitis, especially HLA-B27 uveitis, the distribution of the KBs usually in the inferior part of the cornea, respecting the Arlet's triangle. However, in viral uveitis, this principle is broken and you will find the distribution all over. So if it is mutton fat KBs like this, or very fine small KBs, will be distributed all over if it is non-granulomatous uveitis. And this presentation commonly in chronic uveitis, and if there is acute presentation, you will find the KBs will be distributed all over the cornea, not respecting the Arlet's line. This is very important. So you can see that when you find a patient with unilateral uveitis, with iris changes or iris atrophy, patchy iris atrophy, and elevation of the intraocular pressure and granular KBs, always think on viral etiology. That's why the laboratory investigation is not mandatory for each and every patient. We do it for atypical cases, as we will discuss later. If you are in a strong background based on the patient history and the clinical finding, you can immediately start the antiviral treatment and start steroids. As I said, activity is usually is not that much, +2, +1, +2. Hypopyon is rare in viral uveitis, unlike in HLA-B27 or in Behçet disease. So these are the different patterns that you have to keep it in your mind to differentiate viral from non-viral etiology. This is the sectorial iris atrophy, as I explained before, and this is due to ischemia to the virus. And if this ischemia involves the pigment epithelium, there will be transillumination defect. This is typical for herpes simplex. And of course, don't forget to test the cornea for sensation, especially in herpes zoster. In herpes zoster, there will be marked reduction of the cornea sensation, unlike herpes simplex. Also, it will be reduction, but not that profound as in herpes zoster, and usually preserved corneal sensation in cytomegalovirus. Similarly, don't forget to look for staining. You might find an active keratitis with uveitis, so this is called keratouveitis. So in such cases, you have to modify your topical steroids treatment, and you will provide systemic steroids along with systemic antiviral and so on. Now, before finish the talk about herpes simplex uveitis, take-home message that the clinical pattern and the clinical finding is very useful in differentiating herpes simplex from other viruses, especially the pattern of sectorial iris atrophy, the presence of unilateral hypertensive uveitis, granulomatous or non-granulomatous uveitis, and unilaterality, as I said, that it is 90% it is unilateral. And in doubtful cases, confirmation with PCR is very important. Valve cyclovar now is the first line of drug for choice for patients with hypertensive uveitis. Herpes simplex uveitis, and it should be given orally. All patients they will need prophylaxis after 2 attacks. And don't forget the presence of acute retinal necrosis is ocular emergency, and you should shift to IV antiviral instead of the oral. And keep watch on the presence or absence of HIV when you find atypical presentation, especially bilateral herpes simplex anterior uveitis is a warning sign or red flag that you should search for HIV. Now we come to the second important virus that causes viral anterior uveitis, which is herpes zoster, which is known as varicella zoster virus, because it causes chickenpox initially and becomes dormant in the body, and then when reactivated it would cause herpes zoster virus. This is one of the important causes and serious complication of herpes zoster. As far as herpes zoster ophthalmicus, this is one of the important viruses defined as reactivation of varicella zoster virus, which was dormant for a long time in the trigeminal ganglia. And for whatever reason or trigger factor, this activation will follow the nerve along the first division of the fifth trigeminal nerve. That's the ophthalmic division. And that's why you find the skin rash typical respecting the midline and respecting the dermatome. But this doesn't necessarily means involvement of the eye, that only 50% of cases of herpes zoster ophthalmicus will have ocular involvement. So keep this in your mind when I ask you or present you a picture like this. This is herpes zoster ophthalmicus. Don't say herpes zoster and stop, because herpes zoster ophthalmicus represented 25% only of all herpes zoster cases. The most common location and the presentation of herpes zoster is herpes zoster of the dorsal root ganglia that will the spinal nerves. It will involve the spinal nerves, so you'll find the thoracic area and the chest area is involvement, and the shingles will be in the chest. So this is represents 75% of the presentation of herpes zoster. However, only 25% they will have ocular involvement. So don't say herpes zoster and stop. You should say herpes zoster ophthalmicus. This is one. Number two, remember the figure 50. This disease is characterized by 50, rule of 50. 50% of cases will present as uveitis, and 50% of herpes zoster ophthalmicus will have corneal involvement in the form of hyposthesia, neurotrophic keratitis, or nummular keratitis. And another 50% of herpes zoster ophthalmicus, they will have ocular involvement. As I said, not each and every case of herpes zoster ophthalmicus means that there is ocular involvement. There might have just only skin and lid involvement only, but there is no intraocular inflammations. 50% will present with uveitis, 50% will present with corneal involvement, 50% will have ocular involvement. Okay, so keep this in your mind as far as herpes zoster ophthalmicus. As I said before, that the principle of unilaterality is universal in all viral uveitis. It is, you can see 95% is unilateral. However, in herpes simplex, 90% only is unilateral. And in varicella zoster or herpes zoster, there will be extensive iris atrophy. And there will be necrosis of the retinal pigment epithelium. That's why a transillumination defect will be there. And there will be a segmental iris atrophy with associated elevation of the intraocular pressure, can be seen in 80% of the cases because of the associated trabeculitis. This is, you can see, as compared to the herpes simplex virus. And corneal hyposthesia or anesthesia, this is very common. In herpes simplex is less, but 50% of the cases they have decreased corneal sensation and they will have skin involvement. So this is the common features of the herpes zoster. That's why we say that viral uveitis based on the clinical pattern. Most of the cases you diagnose them based on these clinical findings. You will not need to do PCR or sophisticated investigation for them. Based on the clinical history of recurrence, unilaterality, type of inflammations, associated hyposthesia of the cornea, associated skin manifestations, all this will point to herpes zoster involvement or uveitis. This is a quick comparison between herpes zoster and herpes simplex. As I said, that the extensive involvement of the iris and the severity is more. As I said, that hypopyon is less common, but if it is there, always think on herpes varicella zoster virus. Corneal sensation much reduced in varicella zoster, and corneal edema can be seen, and neurotrophic keratitis is seen in varicella zoster. And varicella zoster is common in people beyond the age of 50 to 60 years, unlike herpes simplex, which has a wide range, and always associated with immune suppression or with diabetes mellitus, chronic kidney disease, patient on transplant, or in psychological defect. The complication of varicella zoster, apart from the ocular the famous ocular complication, is glaucoma and very refractory to treat. Also cataract and neurotrophic keratitis and post-herpetic neuralgia. Another important point regarding herpes zoster that I have to mention, that herpes zoster passes through different stages. You have the prodromal stage, acute eruptive stage, subacute healing stage, and the chronic stage. And this is the diagram showing the overlap between the different stages, between the windows period and the inflammations. So this is important. Why? Because in the prodromal stage, patient will come just complaining of burning pain in the forehead, tingles, hyperesthesia, headache, but there will be no skin manifestations. And this is difficult. We used to miss patient in this area, but you find old patients with hyperemia on the skin or just pain. This pain is characteristically severe pain. So it might be the prodromal stage. Now the acute eruptive stage, this is very important. This takes between 1 to 2 weeks, because in this stage, if we start the antiviral treatment, we can abort the disease immediately. Characterized by erythematous nodules, progressive vesicles, and usually unilateral skin involvement. Now, if you become your patient in this stage, it will be very good that you all abort the attack. If the patient present later, between 2 to 4 weeks, at that time you will have the acute symptoms will subside a little bit. It will be subacute stage with crusting, erythematosis, and hyperpigmentation. And at this stage, you will continue the antiviral treatment, but you have to monitor the intraocular pressure. And if he present after 1 month, you should look for the complications like postherpetic neuralgia, neurotrophic keratitis, secondary glaucoma, secondary cataract, and corneal scarring. So these stages are very important, that you should know the exact time of the onset of the symptoms, so that you know your patient is at risk of the development complication or not. If you pick your patient at this stage, you will prevent this complication. It is very important. Along the clinical features of the herpes zoster uveitis, sometimes you find associated involvement of the cornea, known as keratouveitis, and the typical pattern of herpes zoster corneal involvement is the presence of pseudodendrites. Pseudodendrites differentiated from the true dendrites in herpes simplex by the absence of the terminal buttons. So you can see the branching here, but without terminal buttons. So this is the pseudodendrites of herpes zoster. Now, this is involvement of the maxillary division of the trigeminal nerve, and this is involvement of the ophthalmic division of the trigeminal nerve. This is the frontal branch. Now, there is another question we used to ask the candidate. Now, if there is involvement of the maxillary division of the trigeminal nerve, is the eye is involved or not? Now, the answer for this question is no. If there is pure involvement of the maxillary division, there will be usually crusting and lips over the vesicles over the upper lips, and the lower lid may be involved. However, the intraocular inflammation and the eye will be, there is no any intraocular inflammation. However, the scenario is different if there is a combination of both V1 and V2. That's the ophthalmic division and the maxillary division. At that time, you will find this picture. However, pure V2 involvement is sparing the intraocular inflammations. This is the frontal branch of the ophthalmic division is involved. And as I said before, the Hutchinson sign, presence of Hutchinson sign indicate ocular involvement, and its absence does not rule out ocular involvement. Among the other findings is the posterior segment involvement. As I said, that this is beyond the scope of this lecture, and we have, before we fit the diagnosis for anterior uveitis, to rule out any posterior segment involvement. Now, this is some or a few of the clinical manifestations of herpes zoster uveitis. As I said before, that it can present as granulomatous uveitis if it's a chronic uveitis, or can present as fine dust-like KBs present over the corneal endothelium, not necessarily respect the Arlet's triangle. Now, this is the Arlet's triangle, just I show it here for you. This is the typical presentation for especially HLA-B27. However, in viral or herpes zoster virus, it might go beyond the Arlet's triangle, and you find diffuse fine KBs present as a non-granulomatous uveitis. So similar to herpes simplex, can present as granulomatous or non-granulomatous. Granulomatous is much more common, and they don't necessarily respect the Arlet's triangle. The other thing is that the severity of the inflammation is not that severe, but rarely can present as hypopia. Rarely can present as hypopia. However, very, very rare for herpes simplex to present as hypopia. And always a check for the intraocular pressure. One of the hallmark is the intraocular pressure is high in these cases because of the associated trabeculitis. Now, another important point regarding the Hutchinson sign that we have spoken before. This sign is related to the involvement of the nasociliary nerve. Now, involvement of the nasociliary nerve, they will be supplying the nasal part of the nose and the tip of the nose. So, presence of Hutchinson sign strongly suggests that there is ocular involvement. However, about 34% of cases without Hutchinson sign, they have ocular involvement. So, absence of Hutchinson sign does not rule out ocular involvement. However, presence of Hutchinson sign is strongly suggestive of ocular involvement. You should understand this statement very clearly, and we explain the anatomical basis for this, that due to involvement of the nasociliary nerve. This is what we have said, that this is segmental iris atrophy, very big, large sector involved from the pupillary area up to the limbus, and this area is supplied by one nerve. So this is segmental. Also, some books it is commonly said that sectorial iris atrophy, but what I meant to say that in herpes zoster ophthalmicus it is more profound affection of the iris as compared to the herpes simplex. But even though we cannot just based on the iris finding we differentiate between herpes simplex or herpes zoster, the best way to differentiate is by virology, by aqueous stab from the anterior chamber. However, our diagnosis is presumptive based on the clinical history of the skin rash, history of hypoesthesia of the cornea, and so on. We can say that this is due to herpes simplex or herpes zoster. However, this is very clear sign, as I said, that uveitis is severe, and sometimes in herpes zoster can be associated with hypopia, can be associated with iris atrophy, even in and almost always unilateral. However, if you find bilateral uveitis, think of immune suppression. There might be associated posterior segment involvement. That's why you must, before give diagnosis of anterior uveitis, to look to the fundus, because as I said before, anterior uveitis is diagnosis of exclusion, that you should look to the vitreous, look to the fundus. If they both are normal, you say anterior uveitis. If there is findings, especially in herpes zoster, like acute retinal necrosis, occlusive vasculitis, or choroiditis, so this will not be acute uveitis, acute anterior uveitis, it will be panuveitis. Okay, so this should be very clear. Now we come to the third important virus in this group, which is the cytomegalovirus. This is one of the important viruses nowadays is emerging, and the increased incidence of seropositivity, especially in Asian people and worldwide, has been incriminated as an important cause of viral anterior uveitis. Cytomegalovirus is one of the important causes of viral anterior uveitis, and as other uveitis, characterized by high level of unilaterality and male predominance, and similarly, it has a bimodal distribution in younger age groups and old age groups. So it has a large range of affection, and it has been found that it is very common, especially in the eastern part of the world, in Taiwan, Japan, Korea, South Singapore, China. The seropositivity is very high there. And when we say seropositivity, this doesn't mean ocular inflammations, because seropositive immunoglobulin level in the blood does not necessarily indicate active eye inflammation. We will speak about this when we speak about the laboratory investigation. The presentation of cytomegalovirus uveitis in immunocompetent patient can take four forms: the cytomegalovirus Bosnar-Schlussman phenotype, or cytomegalovirus Fox-Uveitis syndrome phenotype, or present as endotheliitis or chronic anterior uveitis. Now, the association of the people in the Asia with this virus has been related to the association with HLA antigens. So keep it in your mind. If you have any patient with from Asian part of the world and present with these signs of unilaterality, very high tension, which is out of proportion to the clinical signs, and minimal activity or cells or inflammation in the anterior chamber, you should think in cytomegalovirus. So clinical features: very high tension reaching up to the 60 millimercury, and it is said that out of proportion to the degree of inflammation, you find very mild inflammation, +1, +2, but very high tension. Also, you can find corneal edema, which is out of proportion to the level of IOP. You find corneal edema, but IOP is not that significantly high. This is the main feature of immunocompetent patients with cytomegalovirus, because in immunosuppressed patient or patient with HIV, the presentation may take more serious fulminant picture, goes to the posterior segment, causing retinitis and vasculitis and so on. However, we are speaking on immunocompetent patient now. The pathogenesis for the glaucoma, or the elevation of the intraocular pressure, there are different mechanisms: direct invasion to the trabecular meshwork. This is one cause, and as a result, severe inflammation and deposition of the debris in the anterior chamber. This will block the angle, or indirectly through the cytokines and mediators of the inflammations. All this will lead to elevation of the intraocular pressure, and it can be induced iatrogenically by the prolonged use of steroids. All these are indicated. So you can find that the glaucoma can be a combined mechanism: open angle or closed angle glaucoma. That's why these cases have intractable to manage glaucoma, and we have to treat them aggressively. And later, when we discuss about the management, we will speak about special precautions in these patients, even the surgical from surgical point of view. Now, one important point is what's meant by the paradigm shift from morphology to etiology. That previously there are two syndromes of uveitis, known as the Bosnar-Schlussman syndrome and the Fox-Uveitis syndrome, was diagnosed as idiopathic diseases. But now, with the advent on the era of the availability of the PCR, they could recognize and isolate viral etiology for these two diseases, but not in the 100% of the cases, but in large percentage of cases, reaching up to 90% of the cases. They could isolate cytomegalovirus in Fox heterochromic uveitis in eastern part of the world, and rubella virus in the western part of the world. And for Bosnar-Schlussman syndrome, also cytomegalovirus, and sometimes herpes simplex also has been isolated in these cases. So this is make a paradigm shift from clinical morphology, based on the clinical morphology of the case, to the laboratory based diagnosis or evidence based diagnosis. That's why it is very confusing picture clinically to differentiate between the different viruses and the different phenotypes. So you might have a real classical case of Fox heterochromic uveitis with a special clinical manifestation. Also, you might have case of cytomegalovirus with Fox uveitis syndrome phenotype. Similarly, for Bosnar-Schlussman syndrome, you will have classical case and one related to the cytomegalovirus. So step by step, you will learn how to differentiate between these because the management is important. In these cases, the use of steroids, the use of antiviral is very important. Now, one of the classic presentation of cytomegalovirus anterior uveitis, it's present as an acute spike of high intraocular pressure resembling the idiopathic Bosnar-Schlussman syndrome, but it is completely separate entity. It is not related to the Bosnar-Schlussman syndrome, but the presentation it is similar to it. The patient will present with high tension, 40 to 60, with minimal cells inflammation in the anterior chamber, which is disproportionate to the degree of IOP elevation. This is very important because you will have very high intraocular pressure and very minimum inflammation. And also you will find sometimes corneal edema, which is disproportionate to the intraocular pressure. So you find these 2 points. You should keep it in your mind. You'll find very fine KBs in the endothelium, and as I said, that you find stromal edema or corneal edema, which is disproportionate to the elevation of the intraocular pressure. Now, in gonioscopy, you'll find open angle with no synechia or minimal synechia present in the angle, because this is usually open angle. In the idiopathic variety, the attack was just a spike and disappear after a few days after treatment, and there will be no recurrence, usually very rarely recurrence. However, in this variety, due to cytomegalovirus, the recurrence is very common in this type of presentations. Now, how we differentiate clinically between the idiopathic variety of Bosnar-Schlussman syndrome and the cytomegalovirus anterior uveitis that can present or mimic Bosnar-Schlussman syndrome. Now, the first point and the most important point is the cornea. If you find coin keratic precipitates, this is in favor of cytomegalovirus etiology. If you find corneal edema, which is usually disproportionate to the spike of elevation of the intraocular pressure, and you find cells and flare in the anterior chamber, this is more in favor of cytomegalovirus, unlike the idiopathic variety. Another sign, it is said that the Arojas sign, this is due to a linear arrangement of the keratic precipitate near the trabecular meshwork. So you'll find this precipitate near the 6 o'clock down position, very fine linear precipitate. This is known as Arojas sign. This is one of the signs in favor of cytomegalovirus infections. And the reason for differentiation is that these people, if you start with the steroids, they will deteriorate. So you have to start immediately with antiviral treatments. This table quickly shows the difference between the classic Bosnar-Schlussman syndrome and the cytomegalovirus variety. As I said, the presence of coin or precipitates as compared to the round precipitates in the idiopathic variety, and the corneal endothelial involvement is associated with cytomegalovirus infection. That's why we have to do and follow the patient with endothelial microscopy, because they will have serial drop in the cells of the endothelium if we don't treat them with antiviral treatment. The iris atrophy can be seen in the idiopathic variety, however, usually normal in the cytomegalovirus type. And as I said, that usually in the classic variety it is episodic, self-limiting, even without a treatment. However, these people, they have the cytomegalovirus variety, they have chronic course with recurrent attacks. Now, the presence of recurrent attacks, this is also in favor of cytomegalovirus. And the prognosis is poor, because at the end they will have decompensation of the cornea, and they will present like chronic simple glaucoma, they will have cupping and so on. However, the idiopathic variety is better prognosis. Now, the second presentation or manifestation of cytomegalovirus anterior uveitis, it presents as a chronic uveitis, and it has very much a close similarity to the Fox uveitis syndrome, but it is not Fox uveitis syndrome. It is completely separate entity based on the Sun classification. but it has quite similarity to Fox uveitis syndrome in some aspects, that the patient present with very low grade of inflammation, present with cataract and with spikes of high intraocular pressure, and fine or stellate KBs present in the cornea. However, based on the laboratory investigation and the PCR, it is completely different than the Fox uveitis syndrome. And there are certain points when you find in your examination, it is strongly suggest or point towards cytomegalovirus rather than the idiopathic or the classical type of Fox uveitis syndrome. For example, the presence of posterior synechia. That's why it's called the rule breaker. That's the presence of posterior synechia in such scenario is completely against Fox uveitis syndrome, as the classical Fox uveitis syndrome is never associated with the posterior synechia. Another thing, there is no true heterochromia, because there is some atrophy in the iris stroma in patients with cytomegalovirus infection or uveitis, but it is not that atrophy that lead to heterochromia as seen in the idiopathic or the classical type of Fox uveitis syndrome. Even in Fox uveitis syndrome, the heterochromia is not present in all cases, but quite large proportion of cases they have heterochromia. That's why it is the term preferred to say Fox uveitis syndrome rather than Fox heterochromic uveitis. This is based on the Sun recommendation. Better to say Fox uveitis syndrome and avoid to use the term Fox heterochromic uveitis, because this will lead to confusion if you don't find heterochromia. So, the large substantial portion of Fox uveitis syndrome is associated with true heterochromia, and the lighter colored eyes is associated with the chronic inflammation. However, in cytomegalovirus phenotype of Fox phenotype is associated with atrophy of the stroma and very mild, sometimes even transillumination you find it, but it is not a true heterochromia. The other thing, that the degree of inflammation in the chronic variety of the Fox-like cytomegalovirus anterior uveitis, there is inflammation between +1 and +2 cells, which is completely absent or very minimal inflammation. You will find it in the classical Fox uveitis syndrome. So the evolution and the PCR in the laboratory investigation could subdivide some varieties or substantial proportion of the cases which was previously diagnosed as Fox uveitis syndrome into a subclass that is due to cytomegalovirus. And why this division is important? Because of the management. Now, patient with proven to be due to cytomegalovirus, it is mandatory to give antivirus treatment, and perhaps you have to be very cautious with the use of steroids, because steroids will increase the proliferation of the virus. However, if it is the classical type, the first drug of choice you have to treat with steroids. So this is just a quick comparison between the classical Fox uveitis syndrome, which is incriminated to be due to rubella, the classical one, and we compare it with the cytomegalovirus, which has Fox phenotypic presentation. Number one is the bilaterality. Fox uveitis, the classical one, is usually unilateral. However, it might be bilateral but asymmetrical, with one eye more than the other. But it is also unilateral. But in cytomegalovirus, it is always unilateral. This is one important point. As I said, the heterochromia is present in Fox uveitis syndrome, and in cytomegalovirus, there is some iris atrophy, but there is no typical classical heterochromia. Another thing, the posterior synechia, there is no posterior synechia in the classical type. However, it is present in cytomegalovirus, and its absence doesn't rule out cytomegalovirus, but if you find it, this is very strong sign against the classical Fox uveitis syndrome. And the reaction in the anterior chamber, as I said, it is more in cytomegalovirus, and the glaucoma usually in early stages of the cytomegalovirus because of the associated trabeculitis. However, glaucoma presentation in Fox uveitis is very late. Another point is the endothelial involvement. Now, if you find endotheliitis, this is also more in favor of the cytomegalovirus rather than the classical type. Another thing, in the gonioscopy, when you find the some blood vessels present in the angle, this is in favor of the classical type. favor of the classical type. That's why the Amsler sign, when you do paracentesis or during cataract surgery in a patient with Fox uveitis syndrome, there might be hyphema or bleeding. This is called Amsler sign. If by gonioscopy you find blood vessels in the angle, this is in favor of Fox uveitis rather than cytomegalovirus. This is a case, as you can see, the typical classical heterochromia. This is a case of right eye Fox uveitis syndrome. And this is the fine stellate distribution of the KBs seen in Fox uveitis syndrome, which can be seen in both in cytomegalovirus as well as in the Fox uveitis syndrome. However, if you find the classical coin-shaped keratic precipitate, that is in favor of cytomegalovirus. This is the classical coin-shaped corneal precipitate due to endotheliitis. This is seen only in cytomegalovirus infection. And as I said, if the patient labeled with Fox but has posterior synechia and no heterochromia and aggressive glaucoma, you are not looking for atropilla. You must tap the eye for cytomegalovirus. I mean, you are not looking for classical type of Fox uveitis, but you have to rule out cytomegalovirus and try to avoid the term Fox heterochromic uveitis. Try to use the term Fox uveitis syndrome. So this is in a brief how we differentiate between the classical Fox uveitis syndrome and the phenotypic presentation of cytomegalovirus as Fox uveitis. In completion to our discussion about cytomegalovirus endotheliitis, we come to another important point, which is the classification of cytomegalovirus endotheliitis. The classification made on two steps. The first step is to do the PCR first, and based on your high clinical index of suspicion, based on the presence of coin-shaped endothelial keratic precipitates or presence of ocular hypertension and presence of corneal edema, so you suspect that this might be a cytomegalovirus endotheliitis. So the first thing is to do the aqueous tab and do the PCR. Now the possibilities are either the result will be positive for cytomegalovirus and negative for other herpes viruses, so this will confirm the diagnosis of cytomegalovirus endotheliitis. The second possibility is that it is positive for other viruses but negative for cytomegalovirus, so this gives the diagnosis of a herpetic endotheliitis. Herpetic endotheliitis, as we have discussed before, herpes simplex and herpes zoster can present as endotheliitis. The third possibility that it is negative for both, for cytomegalovirus and for other viruses. So in this case, the presence of negative PCR does not rule out cytomegalovirus infection. We have to do another tests like the Goldman-Whitmar coefficient, and we have to do another aqueous tab in another attack of spikes of high tension or high activity. Anyhow, if the test is negative, you should also think for other differential diagnosis for this corneal edema, like post-nasal syndrome or Fox heterochromic uveitis. Now, this is the first step in the classification. The second step in the classification, after the PCR test is positive, so supported by the background clinical finding, there are two possibilities that if you are supported by a coin-shaped based endothelial precipitates or linear KBs, linear similar to the rejection line as we have explained before, like this one, you will find linear precipitates or coin-shaped precipitates. This is strongly suggestive of cytomegalovirus endotheliitis and is named as typical cytomegalovirus endotheliitis. However, if your PCR is positive and you have another signs, you don't have these two important signs, that's the coin-shaped precipitates or linear-shaped precipitates, but you have another signs. For example, you have recurrent chronic uveitis, you have ocular hypertension, you have evidence of corneal edema. So in this case, it is also diagnosed as cytomegalous endotheliitis, but this is named as atypical endotheliitis. Now, the further subclassification can be done based on the distribution and the extension. This is just for the determination of the extension of the endotheliitis into a localized, multifocal, diffuse, chronic, and so on. Now, why this classification is or differentiation is important? Because we have to differentiate this endotheliitis from other causes like herpes virus endotheliitis, as I said, and we will show some of the difference point how to differentiate between both of them, keeping in your mind that even if the PCR is negative, this does not rule out the cytomegalovirus endotheliitis. Its positivity, it's confirm the diagnosis, but if it is negative, does not rule out. We have to do the what's known as the Goldman-Whitmar coefficient. We will speak about it in the laboratory diagnosis. Now, this is a quick comparison between the cytomegalovirus endotheliitis and herpes simplex and zoster endotheliitis. In the lecture of keratitis, about the herpes keratitis, we have spoken about this entity, that herpes viruses can present as diffuse endotheliitis or linear endotheliitis or disciform endotheliitis. And now it is we have to differentiate it from cytomegalovirus endotheliitis. Now, the one point is the inflammation. Usually in the cytomegalovirus present as a chronic indolent recurrent course. The eye usually is quiet, the eye is not red or inflamed with coin-shaped precipitates in the cornea. And as I said before, you will find linear precipitates also similar to the rejection line. The corneal edema is mild because only confined to the endothelium. Unlike in the herpes zoster, which usually present as herpes zoster or simplex as acute or subacute, usually there is more redness in the eye, more inflammation associated with mutton fat, KBs, and granulomatous uveitis. And also there will be associated iris atrophy, unlike in the cytomegalovirus with minimal iris changes. And as I said, that you will see a disciform or diffuse or linear endotheliitis. And the corneal edema is full thickness here. You find involvement of the stroma as well as the endothelium. Unlike in the cytomegalovirus, only the endothelial area. And also the characteristic iris atrophy, which is seen in herpes simplex and zoster. And another point is the endothelial cell loss. You will find progressive endothelial cell loss in patients with cytomegalovirus. That's why specular microscopy is mandatory. Unlike in the herpes simplex and virus and herpes zoster, there is some endothelial cell loss, but not as fast as in this one. So this is grossly a quick differentiation between the cytomegalovirus and herpes or other herpetic endotheliitis. Now we come to the fourth important virus, which is incriminated in the pathogenesis of anterior uveitis, named as rubella. And rubella has been recently discovered to be responsible for a majority of cases of what was diagnosed before as Fox uveitis syndrome. This Fox uveitis syndrome was as idiopathic etiology, but now with the advent of laboratory investigation has been incriminated to be majority of the cases due to rubella. But also cytomegalovirus and herpes simplex also can present as Fox uveitis syndrome. So let's dive and see what's inside this syndrome. As we used to say that the majority of the cases are unilateral presentation for Fox uveitis syndrome, either due to other diseases or due to rubella, but now we will speak about the rubella as a specific entity responsible for the classical pattern of Fox uveitis syndrome. So unilaterality present in 90% of the cases, and the typical presentation of Fox uveitis syndrome is present in 70 to 80% of the cases, because as I said, majority of the cases of idiopathic Fox uveitis syndrome is due to rubella, but this doesn't mean that 100% are due to rubella. Similarly, diffuse keratic precipitate satellite in shape with iris heterochromia, mild degree of heterochromia is present, especially in light-colored irides. The heterochromia is very clear in light-colored irides, unlike in people with the brown color irides. The heterochromia might not be that evident. The most important feature that there is no posterior synechia. This is seen in 100% of the cases. If you find posterior synechia, it is not Fox uveitis syndrome. This is very important. Most of the cases present as cataract in 75% of the cases, and a large proportion of the patient, between 30 to 50%, they have associated vitritis, that they have some cells in the anterior vitreous face. And this is very important because this shouldn't be named as intermediate uveitis, because there is no involvement of the vitreous base, there is no snow poles or snow banking, just a few cells present in the anterior vitreous can be associated with iridocyclitis due to rubella. So this is part of the phenotype of this inflammation, but it is not an intermediate uveitis. You should remember this. If anybody asks you, is there vitritis? Yes, there is mild vitritis, but it is not intermediate uveitis. So this is the classical picture of fine, diffuse, satellite-shaped keratic precipitates with minimal inflammation in the anterior chamber, and the main important, no posterior synechia. If there is posterior synechia, you should revise your diagnosis. This is the main features of the Fox uveitis syndrome associated or due to rubella virus. Now, before we finish the discussion about the clinical pattern of the four common incriminated viruses in the viral anterior uveitis, it's herpes simplex, zoster, cytomegalovirus, and rubella virus. This is a comparison table between the four viruses with certain clinical features. The age, as you can see, that ranges from 20 years old up to 60 years old with bimodal distribution at young and old people. Laterality, almost all of them are unilateral with variable penetrations, but the main feature for all of them is the unilaterality. Perhaps the reverse. If you find a bilateral uveitis due to viral uveitis, either think or revise your diagnosis or think in associated immune suppression. If you have immune suppression, this is the only exception that you find viral anterior uveitis in immune suppressed patient. You will find it bilateral. IOP is high in all of them, but extremely high in cytomegalovirus. And iris atrophy or iris changes is the hallmark feature of herpes simplex and herpes zoster. And some iris atrophy is present in rubella and cytomegalovirus. Rubella can be associated with heterochromia in 70% of the cases. KBs commonly in herpes simplex granulomatous KBs. However, non-granulomatous KBs can be or non-granulomatous uveitis can be seen with fine keratic precipitates. Herpes zoster commonly non-granulomatous uveitis. Cytomegalovirus characterized by the coin-shaped and linear keratic precipitates. Satellite lesions, fine KBs all over the cornea is a feature of rubella. Corneal sensation usually normal to reduced in herpes simplex, markedly reduced to anesthetic cornea in herpes zoster, and normal in rubella and cytomegalovirus. Skin lesions, common feature for herpes simplex or herpes zoster. History of cold and sores is present. And the dermatological involvement in varicella zoster or herpes zoster. Posterior segment involvement, if the patient is immunosuppressed with fulminant infection, they will have acute retinal necrosis. And in rubella, there might be mild vitritis in 40% of the cases. As we said, this is not intermediate uveitis. It is just spillover of some inflammatory cells to the anterior vitreous face, no associated snowballs or snow opacities. And the recurrence rate is high in all of them except for the varicella zoster because of the availability of the vaccine for varicella zoster and usually associated with immune suppression. If the patient gets severely immune suppressed, there will be recurrence. In cytomegalovirus also is related to the immunity. If the immunity is decreased of the patient for any other reason, the recurrence will be high. In rubella, it has no relapsing on and off course, but it is a chronic progressive uveitis or chronic inflammation all the time. So this is the characteristic feature of Fox uveitis syndrome due to rubella. This is a quick comparison between the four viruses, just for your notes. Now we will go very quickly regarding the associated posterior segment involvement in herpetic uveitis, just for the completion of the subject. And we have three patterns of posterior segment involvement, ranging from acute retinal necrosis to a progressive outer retinal necrosis and cytomegalovirus retinitis. We should, as I said, that the diagnosis of anterior uveitis is diagnosis of exclusion, that you must look to the fundus to know whether your patient just pure anterior uveitis or it is a case of pan uveitis. So this is very important because this also will help you in the differential diagnosis. If you find, for example, acute retinal necrosis, so this patient most likely has herpes simplex or herpes zoster. If he has a progressive outer retinal necrosis, this is most commonly due to immune deficiency and commonly associated with herpes zoster virus or along with HIV infections. And if there is the clinical diagnostic picture of cytomegalovirus, also you will point the diagnosis to cytomegalovirus uveitis. So this is very important to look to the fundus for the patient. As far as the clinical features of the fundus picture of the patient with acute retinal necrosis, as I said, this common in younger age group as compared to the progressive outer retinal necrosis or cytomegalovirus retinitis, and commonly associated with either HSV or herpes zoster virus, and usually seen in immunocompetent patients and commonly unilateral. So these are the most common features, as well as it is characterized by peripheral necrotizing retinitis and triad of retinitis and occlusive arthritis and severe vitritis. And surprisingly, the degree of vitritis is related to the degree of retinitis. That's to say, if you find very small patch of retinal involvement, so you will find mild degree of vitritis. If there is severe vitritis, you will find large area of the retina is involved, characterized by circumferential opacification of the retina at the periphery. Usually start at the periphery and progress slowly, very slowly to the center, and as multiple spots or coalesces together, like this one. They will start as a small multiple spots, and at the end they coalesces together and will be associated with occlusive vasculitis. Another thing, it is painful. That's why it is commonly associated with scleritis. So if you have to examine the anterior segment for evidence of viral uveitis by finding the keratic precipitates, as well as you will find scleritis. So this is most likely due to acute retinal necrosis, and the pain in acute retinal necrosis is due to associated scleritis. So this is one of the causes of painful loss of vision is due to acute retinal necrosis. At the end, these areas will heal either with the treatment or without, but the patient is prone for retinal detachment and retinal holes. There is high risk reaching up to 70% of these cases. The management should be immediately start with antiviral treatment, and also you have to handle the associated vitritis after you control or after the start of antiviral treatment. You can add steroids. The other differential diagnosis of acute retinal necrosis is a progressive outer retinal necrosis, which is characterized by multifocal retinal opacification with the non-granular borders. You can see this is multifocal, and there is no clear distinction between the borders, that at the end they coalesce together and spread toward the center, and also may be associated with disc edema. And this sign, usually the blood vessels are normal. There is no associated vasculitis as we said in acute retinal necrosis, but there will be a shadow or hue for the veins, especially for the veins. This is characteristic for progressive outer retinal necrosis. Apart from that, this is common in immunocompromised patient with HIV positive or CD count less than 100, so you will find no vitritis, and it will be very fulminant and very rapid progression. So there is no associated occlusive vasculitis as compared to the acute retinal necrosis, which is characterized by occlusive vasculitis, hemorrhages, and retinitis and vitritis. This is the triad for acute retinal necrosis. Both of them prognosis is poor. Patient is prone for permanent blindness and also retinal detachment. This is a quick comparison between acute retinal necrosis and progressive outer retinal necrosis. As I said, acute retinal necrosis in immunocompetent patients, commonly due to HS virus or HV virus, that's herpes zoster. Progressive outer retinal necrosis can be seen in herpes zoster with immune suppression or along with HIV infection. Finally, about the cytomegalovirus retinitis, it has the characteristic feature of cheese pizza appearance or cheese and ketchup appearance, which is seen due to severe necrotizing hemorrhagic retinitis, as you can see here, and it is characterized by severe retinitis. Now, there is one interesting thing, that retinitis is a common feature of viral infections. However, in scleritis, usually it is non-necrotizing. It is commonly non-necrotizing scleritis due to viral infections. However, retinitis is usually necrotizing. Just keep it in your mind. To the opposite for bacterial involvement. Now, bacterial involvement of the retina is usually non-necrotizing in the form of chorioretinitis or granulomas like this. However, bacterial involvement of the sclera may be most likely associated with necrotizing scleritis. due to trauma or local surgery. So keep this controversy between these two together. That is, viral scleritis usually non-necrotizing, but retinal viral retinitis usually necrotizing retinitis. Our bacterial retinal involvement is usually non-necrotizing, but bacterial scleral involvement may be necrotizing. And this is the typical appearance involving the macula and the central area. So these patients should be immediately start with antiviral treatment. This is regarded as extension of the immunity becomes very poor in patients with cytomegalovirus seen in immunocompromised patients. As I said, don't forget to examine the anterior chamber because this gives you to the clue for the diagnosis. So also this is regarded as opportunistic infection. That is cytomegalovirus seen in association with HIV infection. Now we come to the laboratory investigation for the this viral uveitis as a general. Now the gold standard is the PCR. The PCR, especially the multiplex PCR, you can see that specificity reaching up to 95%, and it have covered a wide range of viruses. You can see in the herpes simplex virus sensitivity up to 95%, specificity 95%, varicella zoster virus, cytomegalovirus, rubella. Rubella sensitivity is variable. Why? Because the virus load inside the anterior chamber is very low. So you have to consider this, and you have to depend not only on the PCR, you have to do another tests, as I said, the Goldman-Whitmar coefficient. I will speak about this just now. But now the gold standard is the multiplex PCR is very important. You should mention this one, that we have to confirm our diagnosis based on the PCR. But the question, is it mandatory for each and every case suspected of viral uveitis you do PCR? The answer is not. The PCR is expensive, it's not affordable for everyone. So it is done in atypical presentation. When you have atypical presentation, for example, patient with granulomatous unilateral uveitis, so this is suspicious, or feature suggestive of viral uveitis, but still you are not in a solid background, so you have to do the PCR. Patient with bilateral disease, as we said that always viral uveitis is unilateral, but if you have bilateral disease, you have to confirm. Or if there is first episode of viral and you want to establish and confirm the diagnosis, so that you will set up your plan for further management and follow up and prevention of recurrence. Also, if there is failure of treatment, so if you propose one diagnosis and you start the treatment but there is no response, so you have to revise your diagnosis and confirm it by laboratory and do the PCR. In immunocompromised patients, because you are going to use steroids, so you have to confirm your diagnosis before you use the steroids. The gold standard is the multiplex PCR by an aqueous tab of about 0.5 to 0.2 millimeter. This is important. Now, what PCR do? PCR is amplification of the virus DNA. However, if you don't find the virus DNA, we can look to the inflammation from another side, that we assess the local body immune response. That's the immunoglobulins that's formed by the eye inside the anterior chamber against that virus. This is called the Goldman-Whitmar coefficient. And for certainty, they compare the concentration of the immunoglobulin against the virus inside the anterior chamber with the same level of the immunoglobulin formed by the virus inside the serum. So it is a ratio between the level within the aqueous humor and the level of the same immunoglobulin against the same virus within the serum. So if it is value greater than 3, this is a strong indicator for intraocular inflammation and production. Between 2 to 3 is borderline. Less than 2 may be due to local production of immunoglobulin, but not necessarily confirm the diagnosis. So we have to do the PCR first. If it comes to be negative, this doesn't rule out the disease. You have to go for Goldman-Whitmar coefficient. Okay. Now, another point that, as I said, that the sensitivity of the PCR depends on the virus load, and it is highly sensitive in the first 1 or 2 weeks. So if you miss this period, you most likely will find it negative. However, you should repeat it again, and especially in a typical presentation. This is very important. As I said, about the Goldman-Whitmar coefficient, it measures the local production of the antibodies inside the anterior chamber, and its value greater than 3 is significant. And if it is less, you have to you have to repeat your assessment again. If you have negative with Goldman-Whitmar coefficient and negative PCR, this rule out your infection. However, combined appearance of the PCR and Goldman coefficient increase the sensitivity to 90%. So it is very important. And as I said that usually we start with based on the clinical features, confirm your diagnosis. If you are 100% sure from your clinical features, you can start the treatment immediately, not necessarily you wait for the PCR. However, in a typical presentation, you will do the PCR. If it is negative, you go for Goldman-Whitmar coefficient. If it's still unclear, there is new generations of PCR, very sensitive. You can try them, but as I say, this is an expensive tools. Now, as far as our discussion for the medication for viral uveitis, I will discuss here special informations which are very important for those who are willing to appear in the FRCS as a FRCS parallel. So you should keep it in your mind. Number one, as you know, that the biologic treatment, which is a new trend nowadays in the management of uveitis, is mainly meant for non-infectious uveitis. And one of the recommendation is that you have to rule out viral infections or any infectious cause of the uveitis before you start thinking for using the biological treatment for any type of uveitis. So the standard answer for anyone who asks you, is there any rule for biologic treatment and viral uveitis? The answer will be no. But you should know the some exceptions and some reasoning behind why this contraindication of the biological treatment in viral uveitis. As you know that the standard biological treatment, mainly the most common one, the anti-TNF and anti-interleukin 6, are generally contraindicated in any type of viral uveitis or any other causes, even bacterial uveitis, because they are immune suppression. They have a role in the immune suppression, and as you know, these viruses becomes dormant inside the tissue. Once there is immune suppression, this will enhance and potentiate the replication of the virus, and this will worsen the retinitis progression, and patient may be worsened to acute retinal necrosis. So the reactivation risk is very high in these cases. So it is absolutely contraindicated to start this medication for these patients to control the inflammation. Now, there are certain exceptions. For example, the presence of comorbidity. For example, let's suggest or assume this scenario. If you have this dilemma that patient with known case of Behçet disease and accidentally by serology you discover that he has seropositivity for hepatitis simplex virus or zoster or zoster virus by finding high IgG level. So even you did the PCR for the aqueous tab and you find it is negative. Now, what's your decision about the management of this case? If he's, for example, there is indication for the use of biological treatment in this patient, or he's steroid resistant, or he developed complication from steroids. Now, the answer or the to answer this question, there are many aspects. First of all, seropositivity in that's you find IgG level in the serum for hepatitis simplex, herpes simplex or varicella zoster virus is not indicative of active ocular inflammation, especially you are supported by a negative PCR test. So when you have a patient with seropositivity, this doesn't mean that he has an active ocular inflammation. More than 90% of the population, they have seropositive HSV and VZV. So the gold standard for our management of the patient is based on the PCR. If the PCR is negative, this is indicate that your patient has no active viral uveitis, and the uveitis that you are seeing in the patient due to worsening or uncontrolled Behçet uveitis. This is number one. This should be kept in your mind. So as you know, when there is indication to use the anti-TNF or the use of immunosuppression or biological treatment in Behçet disease, if these two predeterminants are fulfilled, so you can at that time you start the anti-TNF or the biological treatment, provided you do antiviral cover for your patients, because even the patient has seropositivity, which doesn't mean that no active ocular inflammation, but as you know, the biological treatment may reactivate a dormant virus which is present dormant in the ocular tissues or in the trigeminal ganglia. So the recommendation is that, like this: number one, you make sure that he has PCR negative. Number two, use antiviral cover for the patient because he is seropositive. So you can use the vanciclovir or whatever antiviral available, and then you start the biological treatment. This is the sequence of management of this patient based on evidence-based study that this is the indication. Because if you neglect this case, for example, this is a Behçet disease, and you know Behçet disease is a serious disease, it's not a simple disease. If you don't control the inflammation, he will be exposed to a life or sight-threatening complications that mandate you to interfere in a proper time by using this biological treatment. So this is the sequence of management of this case. Make sure that the PCR is negative. He has serology positive. Do antiviral cover, then start immunological treatment. The common one which is used for viruses itself is anti-TNF, but for Behçet disease we have a special scenario. I will explain it in the next slide. Now, the biological treatment. Now, another biological treatment which is suitable for Behçet disease, which is the interferon alpha. The advantage of interferon alpha that it is a combination of both. It is a biological treatment that modulates the immunity of the patient, as well as it acts as antiviral. Previously, it is if or it is recently FDA approved for the use of hepatitis C cases, but now it is used even for Behçet disease as off-label. There is no FDA approval for Behçet disease, but they found that it has a very strong effect in modulating the inflammation in patients with Behçet disease. So it has a double effect. It has an antiviral activity as well as or biological activity or immunological activity as immunosuppressant. So this will be ideal for these such cases with for example, hepatitis, herpes simplex positive or herpes zoster positive cases with Behçet disease, so that you can use interferon provided that you have the PCR is negative. This is very important. PCR is negative. So in these cases, you need not to do antiviral cover as long as you are using the interferon. However, if you use other immunological agents, you should use antivirus cover. Now, the other exceptions for the use of biological treatment in uveitis is the use of anti-VEGF. Now, anti-VEGF, they are not immune modulators that they decrease the immunity, but they act against the vasoendothelial growth factors, so prevent the new vascularization. And as you know that in many cases of viral uveitis, there might be severe vasculitis leading to ischemia and new vessels formation or intractable macular edema, or before surgery like vitrectomy, you want to do vitrectomy for patients with organized vitreous hemorrhage like in vasculitis and so on. So in these cases, the use of anti-VEGF found based on a clinical study that it hasn't role in the immune modulation, and you can use it in such cases. So this is the exceptions for the use of biological drugs in the management of uveitis. Number one, you can use anti-VEGF. Number two, you can use interferon in patients with Behçet disease, provided seronegative PCR. Number three, in what's known as immune recovery uveitis. Immune recovery uveitis, we explained this before, that when you have a patient with HIV and herpes simplex, for example, once you start the HART treatment, which is the highly active antiretroviral treatment, due to recovery of the immune system, the patient may sustain severe immunological reaction. Even the virus is dead and the virus is not there because of the antiviral cover, but the patient will sustain severe immunological reaction due to the recognition of the immune system to this virus antigens. In these cases, usually steroid is used, but in some cases, very exceptional cases in which the inflammation is very severe, that is not controlled with steroids, the possibility of using biological treatment is there, provided under complete antiviral cover. Now we will discuss
some points about the management of this viral uveitis. We will mention some of the complications, and we will speak briefly about certain important points and actually important topics, especially for FRCS candidate, which is the association between or how to manage a cases of herpes simplex or herpes zoster or cytomegalovirus in association with HIV patients. And this is a usual combination that you will may face in your daily practice. So the complications usually by this level of this lecture, you know almost all of them, mainly cataract, glaucoma, and corneal scarring. And this is apart from the posterior segment involvement in the form of cystoid macular edema or vasculitis and the complication related to the new vascularization and so on. So these are the main complications. As you can see, that cytomegalovirus carries a high proportion of these complications, and the importance of management of these cases because they are not like ordinary cases. The management of these cases need special precautions, especially glaucoma, which sometimes is very refractory to treat and very difficult to treat, even with full anti-glaucoma medications, because of the chronicity of the inflammation and the multiple etiology, as explained before, the mechanism of glaucoma due to direct invasion of the virus itself into the trabecular meshwork, or as a secondary to the mediators of the inflammation and the deposition of the debris of the inflammation in the angle. So it is a double mechanism glaucoma, a combination of open and closed angle glaucoma. The management is not easy as far as the medication as well as surgically. Even surgically, the success rate is limited. For ordinary trabeculectomy, we need to go for a shunt operations and early to manage these cases because they will have intractable glaucoma in the future. So these are the most common complications. Even in cataract surgery, you have to take special precautions. They will have weak zonules. The tendency for bleeding in the anterior chamber is high, especially in people with Fox uveitis syndrome, what's known as Amsler sign, due to new vascularization in the angle. And the use of steroids after the surgery, this may induce or flare up the inflammation. So you need to weigh the balance, the benefit against the risk, and so on. All of these cases need antiviral cover before the surgery because of the risk of flare up of the complications. Corneal scarring, as you know, all the layers of the cornea can be involved in these viruses, from the epithelial problem to the stroma to the endothelium problem to an permanent corneal opacity and the risk of the need for penetrating keratoplasty, which will add more burden to the patients. So these are the most common complications. You should take care of these cases and try to avoid the significant visual loss from these patients. As far as the management, there are certain general guidelines that we have to use antiviral treatments, and sometimes we need also steroid sparing substances, other anti-inflammatory treatments, and we with the plus minus the use of steroids, of course, in these cases with the limited restrictions, and you will control the associated complications like the elevation of the intraocular pressure, use of mydriatics, and so on. And the treatment regime ranges from management of the acute stage of acute inflammation. There is a specific regime for the first 2 to 3 weeks with the specific doses and types of the antiviruses and the antiviral treatment. And then you will shift to the prophylaxis regime with another doses for a longer duration, not less than 12 months, that's 1 year, because the risk of recurrence is high, especially in cytomegalovirus. So you need to closely monitor your patient, closely draw a chart for your patient, the time against the spikes and the inflammation inside the anterior chamber. So it is not a simple cases. You have to manage them very carefully. And as I said, for example, anti-glaucoma treatments, the patients may have intractable glaucoma. Some drugs should be avoided, like prostaglandin analogs in these patients, which will exacerbate the inflammation. Since we are speaking about the herpes simplex uveitis and cytomegalovirus uveitis, we cannot neglect the coexistence of HIV in association with these viruses, because the common factor for them is the immunity. You know that herpes zoster, for example, is associated with low immunity with old people. HIV is associated with low immunity. So it is quite often in your daily practice you find a combination of these viruses together. So this will alter your clinical presentation and you might have a typical presentation, especially if you have a bilateral disease. This is very rare in immunocompetent patients, most likely refers to immune suppression. You have to check for the CD count. If it is less than 200, indicate element of suppression. If it is less than 50, the management will be changed and the use of drugs will be changed. So this is very important. Common factors for all of them: the presence of hypertensive uveitis with minimal inflammation in the anterior chamber. The presence of posterior segment involvement also will points to the association of immune suppression, especially in cytomegalovirus. So you should keep watch for all these signs and your clinical skills to manage the patient properly. For antivirus, for anti-HIV, the recommended and trend nowadays is the use of HART treatment, which is highly active antiretrovirus treatment. And this is very important. Use it in conjunction with the antiviral treatment available according to the type of the virus. You have to use aggressive treatment in the form of injectables, acyclovir or ganciclovir or valciclovir. Now, the use of steroids is not advised in the presence of HIV. It is not advised unless in very limited indications, what's known as immune recovery uveitis. These patients, after the start of heart treatment, their immunity will be recovered. The virus will die and no more is present with the use of antiviral. However, once the immune system recovered, there will be severe immunity reaction due to the recognition of the virus antigens, and at that time you might need some use of steroids under very, very limited indications. So this is the only indication for the use of steroids along with HIV cases. However, preferably not to use them because they already immune suppressed. Here in this slide, I will try to summarize for you how you can understand easily how you manage your case based on the finding you find in the patient and based on the type of the virus is present. Now, broadly, the antiviral treatment or the management of these types of viruses is based on two important factors. Number one, the location of the involvement. If it is involving the anterior segment or there is immune suppression and involvement of the posterior segment. The second determinant is the immunity of the patients, if your patient is immune competent or immune compromised. So this is very important two factors. If you understand them, you can manage your case clearly and keeping in your mind the precautions or the contraindication for other drugs. So if we are dealing with a patient with immune competent, either herpes simplex virus or herpes zoster or cytomegalovirus, and usually the inflammation or the uveitis is confined to the anterior chamber. In these cases, if the patient has proved and documented cytomegalovirus clinically as well as by PCR, now the topical ganciclovir will be enough for these cases, and better to avoid the use of oral or IV ganciclovir in these cases because it will not reach to the anterior segment with good concentration. However, only topical ganciclovir has very good bioavailability in controlling the inflammations. However, in herpes simplex and herpes virus, which is usually categorized together, we start immediately with oral valciclovir. Why valciclovir? Because it is effective against both herpes simplex and herpes virus infections. So we start with oral treatment. So you can note the difference in cytomegalovirus with start with topical ganciclovir. However, herpes simplex and virus would start with oral valciclovir. This is provided your patient is immune competent and the inflammation is confined only to the anterior segment. Now, what's the role of steroids? There are different studies, different regimes, but generally they agree that we can use steroids in these patients to minimize the inflammations. Usually, just 2 drops is enough in herpes simplex and herpes virus, and very rarely you will need to use systemic, but usually only drops is enough, and after that you need to taper them slowly. Some people advise not to use any topical steroids in cytomegalovirus because this will induce more damage to the endothelium and endotheliitis. So advise better not to use topical steroids. However, some advise to use subconjunctival injection rather than topical. Others, they say no, that you can use topical steroids. Now we let's presume the other scenario that if your patient has one of these viruses along with immune suppression, and immune suppression means the patient he's already have HIV infection or he's under immune suppression due to transplantation or whatever the reason. So now the immune suppression is diagnosed by CD count T cells less than 50, and in these patients you will find both anterior and posterior segment involvement in the form of cytomegalovirus retinitis or acute retinal necrosis, and there will be disseminated inflammation in the whole eye. So this is an ocular emergency, especially for cytomegalovirus retinitis, and we have to preserve the other eye because the inflammation may becomes bilateral in these cases. So you have immediately to use IV ganciclovir instead of the topical drops that we have advised before. Now we will shift to the IV medications. For herpes simplex virus and herpes zoster, we will shift to the IV acyclovir. IV acyclovir. This is very important. Now, steroids is totally forbidden and contraindicated if the CD count is less than 50, unless in very special situation, which is known as the iris. This is iris, which is immune-related uveitis. Now, these exceptions that the patient, after the load of the virus is reduced by the introduction of the anti HIV treatment named as the heart. This is the heart treatment. If the patient has HIV and this one of these viruses, in combination with the antiviral, they will start the heart treatment, which is highly active antiretrovirus treatment. Patient will start improving the virus load. At that time, the immunity will improve and the immune system will recognize the virus antigen, so the patient will have severe immunological reaction. In this situation, we have to give steroids when there is iris or IRU, that's immune-related uveitis. So keep this in your mind. This is the only exception to use steroids in the presence of CD count less than 50. Once the patient starts improving, he will sustain severe reaction. So at that time, in conjunction with the antiviral treatment and heart treatment, you have to give some steroids. Otherwise, better to not to give steroids in these patients. Now, in the coming slides, we will discuss a few cases from real-world scenario, so that we can apply whatever we have taken, how to solve these problems in training for you for tackling these cases, especially in the exam if you face such a scenario. Now, the first case, 45 years old male patient presented with a history of 3 days painful red eye with blurring of vision, examination 618 and ciliary injection, mild cells and flare, fine diffusely distributed KBs, satellite appearance, intraocular pressure is high, reaching to 48 millimercury, and no iris atrophy, no prior ocular history or corneal and corneal sensation is normal. So the first thing that points to a viral etiology, that male predominance, as we have said before, unilaterality, that's only the right eye's involvement, and has acute onset. Now this scenario has acute onset with mild cells and flares, not that severe, no history of hypopyon, and mild ciliary injection. Now the strong positive point, presence of satellite shape, finely distributed KBs. This strongly points to either cytomegalovirus or herpes simplex can be present with this scenario, although herpes simplex commonly present as granulomatous uveitis. However, can be also present as non-granulomatous uveitis, but commonly as granulomatous uveitis. But here he mentioned fine distributed KBs means non-granulomatous uveitis. Now the other positive point, the tension is very high, 48 millimercury, which is points this is in favor of cytomegalovirus. Also, herpes simplex can present with high intraocular pressure, but not to this extent. Now, the important negative point is that no iris atrophy is there, which is also in favor of cytomegalovirus, because cytomegalovirus, there will be some changes in the iris and some iris atrophy, but is not significant as in herpes simplex, which is present with sectorial iris atrophy, as we have explained before. And here he say there is no or normal corneal sensation. So this is against herpes simplex or herpes zoster. So from this scenario, most likely it is cytomegalovirus, but we will see how we will proceed with the case. Like this case, there is no very strong ground basis to say that this is cytomegalovirus. So the final decision will be for the PCR. So what's the most likely diagnosis and what's your next step? you can see that the answer is cytomegalovirus. Fine, diffuse KBs, very high intraocular pressure, no iris atrophy, normal sensation. So the next step should be a PCR to exactly rule out other viruses, because we want to decide if it is cytomegalovirus. We will use combination of steroids and antiviral treatment. And as we said before, never start steroids alone without antiviral cover, especially in cytomegalovirus. So these are the very important points. As I said, fine satellite KBs, very high intraocular pressure is very high in cytomegalovirus, more than 40, and no iris atrophy. So most likely this is a case of cytomegalovirus anterior uveitis. The second case scenario, this is a female patient with, which is known case of herpes simplex uveitis, with the previous 3 episodes or attacks of uveitis. She's already on valve cyclovar 500 milligram, which is the prophylactic dose, but stopped over the last 2 months the treatment, as she said that I am feeling fine. Now the patient present with recurrence with a few cells and flare, and already she has old iris atrophy from previous attacks, and intraocular pressure is mildly high. So now the diagnosis is already known as herpes simplex, but now she's presenting with recurrence. Now the question, how do you manage this acute episode, and what do you counsel about the future prophylaxis? Now the question regarding how to change the dose from the prophylactic dose to the therapeutic dose, the diagnosis is already known, and what you will tell your patient and discuss with him regarding future prophylaxis. So we change the dose from the prophylactic dose to the treatment dose, which is 1 gram 3 times a day, and topical steroids should be used 24 to 48 hours after the initiation of antivirus treatment. And since the patient already has 3 previous attacks and now he present with 1 attack, so a lifelong prophylaxis is worth it in this case, because the recurrence rate will be very high. So this is the important points, that you have to educate your patient that self-discontinuation of the treatment will lead to the recurrence of the problem, and she should be on lifelong prophylaxis on now the acute attack treated with the treatment dose, and then keep the hair on the maintenance dose. Another case scenario to augment our understanding of the subject, that a 45 years old patient refers to the uveitis clinic, already diagnosed as primarily as Fox uveitis syndrome, due to the presence of diffuse fine satellite keratic precipitates. And see, this is satellite keratic precipitates fines, can be seen also in cytomegalovirus, and mild vitritis. However, upon your examination, you note a clinical finding that is considered a classic red flag against the diagnosis of rubella-driven classic Fox uveitis syndrome. As you know that we said that the majority of the classic Fox uveitis syndrome has been identified due to rubella. But there is one sign, if you find it, this is completely against the classic Fox uveitis syndrome, and it will point to another cause of this syndrome, which can be due to cytomegalovirus or other virus. So the question here, what's the red flag sign that if you find it, it is strongly against the classic Fox uveitis syndrome? Unilateral involvement, can be present in cytomegalovirus phenotypic Fox-like uveitis, or in the classic idiopathic Fox uveitis syndrome. Presence of posterior synechia, this is very important now, because in the classic type, never you will find posterior synechia. If you find posterior synechia, this is points to another viral etiology, most likely cytomegalovirus. As you know that we said that the presentation of cytomegalovirus can be as Fox-like uveitis syndrome, or Bosner-like uveitis syndrome, or a chronic manifestation, or like endotheliitis. So one of the differential diagnoses of Fox uveitis syndrome is cytomegalovirus. Elevated intraocular pressure and mild anterior cells, can present in both. So the answer here will be the presence of posterior synechia. This is against the classic Fox uveitis syndrome. Now the other case, 38 years old patient presents with recurrent strictly unilateral episode of extremely high intraocular pressure. This is very high. So this figure, keep it in your mind. And mild anterior cells in the reaction in the anterior chamber. On a slit lamp, you find coin-shaped keratic precipitate arranged in a linear pattern over the inferior trabeculum. This is typical and classical for cytomegalovirus endotheliitis or cytomegalovirus uveitis. So what's the most likely etiology here? As I said, cytomegalovirus, because once you find coin-shaped keratic precipitate, this is very strong pathognomonic sign for cytomegalovirus uveitis. So the correct answer is C. Now, the other last scenario, due to over the past 2 decades, the advent of anterior paracentesis with PCR and has drastically changes how we classify anterior uveitis syndrome, which of the following statements most accurately reflects the current virological understanding of these entities. What you want to say that previously there was some idiopathic syndromes like Bosner-Klussmann syndrome or Fox uveitis syndrome, and the exact etiology is not known. Now, because of the advancement in the laboratory investigation and the PCR per se has changed, we found that majority of Bosner-Klussmann syndrome is related to cytomegalovirus or herpes simplex, and the majority of the Fox uveitis syndrome, the classic variety, is due to rubella. So now you want to choose one of the correct answers. Cytomegalovirus has been proven to be the primary causative agent of classic Fox uveitis. This is wrong, because the classic Fox uveitis is incriminated due to rubella. Rubella virus is the most common identifiable cause of Bosner. This is wrong. Rubella is related to Fox, and cytomegalovirus is related to the Bosner-Klussmann syndrome. What was historically called idiopathic Bosner and Klussmann syndrome is now largely recognized to be herpes simplex and cytomegalovirus. This is true. So the correct answer will be C. Now by this level we nearly reached to the end of this lecture, and before I finish with you, I just like it to remind you with certain important perils, very important for your clinical practice, as far as the differential diagnosis of viral uveitis and the pattern recognition. For when you find a unilateral presentation with high IOP, always think of viral uveitis, and also other pattern recognition in the form of iris atrophy or any other specific type of keratic precipitates. Also keep in your mind that the final confirmation is by the use of PCR, and other important points that we have discussed here, keeping in your mind the possible complication that the patient might have from this viral uveitis. This is the answer for the initial questions that I have presented in the beginning of this lecture. For those who are interested, this is the correct answer for your revision. And I am looking forward to meet you soon in the next lecture, which is about the bacterial and parasitic infectious uveitis. We have finished the viral uveitis. Now we will cover the bacterial and parasitic uveitis, and this is a few of the references. Looking forward to meet you soon in the next session. For that time, I hope that you will be safe and in a good health.